thank you all for coming. And I think it's as important that you get to know each other as you get to know us. Because as you guys will tell us, you know, everybody in healthcare knows everybody, especially in Connecticut. So thank you to you. I want to recognize my colleagues in the audience. Dr. Teresa Tai, many of you have had Teresa for some health management. So thank you, Teresa, for coming. And Dr. Mary Schramm, who we're doing, you know, we have a false claims book club. We have this interest in the False Claims Act. You know, there's about 2 of us on campus, 2 of us probably in the world that get excited about it, but. Well, too, yes, Jen Herbst. All right, so with that, I'm just gonna make some very brief remarks and turn over the program. So as faculty, director, and advisor to this wonderful club, why would you get involved? And I can't say enough about the support that we have had from our collaborators. You know, from Gina, from Steve, Mertz. You know, Steve, I think, has really kind of been my co-partner as chair of this department. So Bill, we won't do the same thing to you because I think Steve actually probably clocked, I don't know how many advising hours with our kids, but, well, not kids, grown people with professionals. But, so there's, oh, and Martha, your internship, I think Martha was our previous co-president of this club, and it's wonderful to have you back. And I think your internship really came as a result of your membership here and your work here. So you just finished up an internship at Yale New Haven Hospital. You're still there?
Better?
Yes, but she's looking for employment, so, you know, I'm a big proponent on everybody supports everybody. The thing that's going to set us apart from that other school with the hockey team is really you guys supporting each other. I mean, that's really makes a difference. But that's why you join this club. Each year we sponsor educational programs. We've done several. And ACHE in the community sponsors a number of things. And you guys will probably talk to that today. So, you know, I would also, as someone who really cares about you guys, strongly urge you to take advantage of the reduced rate. And I'm not going to go over it because I think you guys are going to go over that. But when we brought that to your attention, you set up a system so you can get into the club at a reduced rate as a, you know, as an adult professional student. So you almost cannot do it. I have some testimony. I don't know if you guys remember Andreas, but Andreas spent a lot of time with Steve. He actually ended up doing a performance improvement position in the Hartford healthcare system. But it was really this club and the network and the programs that he attended that really both helped him decide what his career path was going to be, but actually put him in a position where he had a network to start doing things. This is just an example, you know, and the other thing is because of the cachet of Quinnipiac now and ACHE, you know, we've had the Commissioner of Health here. I've had both commissioners. I've had Jill Mullen and Galvin here. We've had some high-level executives that have come to our programs. This is an example of the program we did a couple of years ago. So, and this is even more reason. This is one artist's rendition of healthcare reform. So, yeah. We can't do it alone as newly minted healthcare management people, or even, you know, people who've been in the field. The more that we work with one another and we network with one another and we play off of each other's expertise, all the better. And this is what this environment brings to us. So, I love that slide. So, as we try to go through all that, we also need more people who know and understand the business of healthcare. And, you know, this is the organization that supports that. This is not a clinical organization. This is an organization that supports people who understand, who know, who want to be involved in creating better systems, looking at value, lowering cost, improving quality in the system. So with that, I'm just going to leave you with the last slide. Many of you know this. We have several tracks We have an MBA healthcare management track. We have a healthcare compliance certificate, which is really a growing area right now. We have a long-term care certificate. We have an MS in organizational leadership with a healthcare management track. So, any of you want to discuss that or pursue that, we're willing to do that. So I'm going to ask our current co-presidents, who are right here, Linda Patine and Kristen Edgerton. She'll tell you how to pronounce her name correctly. Anybody tell you I have name dyslexia, but I don't not love any of you any less.
So I'd just like to thank everybody for coming tonight and putting in the time. And ACHE really is a wonderful organization, so I'd encourage everyone to join. And I'd like to just now thank the members of the committee who put this program together. They are my co-president, Kristen Edgerton, who also arranged for the room and the food for us. Angelica Walter, she arranged for the videotaping, so this is our first attempt at that, as Angela said. We have Jonathan Stewart, who designed the brochure, Ann Colasso, who's on the committee, Katie Lasowitz, who had to leave for class, so as we are all still in class. Right, exactly. Nancy Logel and Brianna Granatelli, I'm sorry, who manned the registration table, and Lavinia Cretescu, who arranged for the name tags. So she also is in class tonight. But I'd just like to thank everybody who helped us with this and encourage anybody who would like to join the committee to come and join us. Our next meeting is going to be next Wednesday evening at 6:15. It is in the School of Business, room 210, and we're going to be planning a program for the spring. So please come join us. And now I'd like to introduce Kristen.
Hi, everyone. Thank you for coming. I wanted to introduce to you Gena Calder, Administrative Director of Geriatric Service and Patient Relations at Bridgeport Hospital. I'm sorry, Gina, I didn't know you were speaking. And Bill Jennings. And I wanted to give you a little bit of background on Bill, who I'm fortunate enough to work with both of them, actually. And since coming to Bridgeport Hospital in August of 2010, Bill has both physically changed the environment and changed the culture and made our hospital into a beautiful place. So clearly people are getting the great care that they expect after seeing the newly transformed space. Patient satisfaction scores on the Press Ganey have increased from 15 to 88%. And while employee satisfaction is at the 86th percentile for hospitals nationwide as of February 2013. He has taken steps to get all staff involved in increasing patient satisfaction and has created a culture of safety at the hospital. So please welcome our ACHE Regent, Bridgeport Hospital President and CEO, very approachable and down-to-earth CEO, and Executive Vice President of Yale New Haven Health System, Mr. Bill Jennings.
I had no idea I was going to get such a kind introduction. I actually didn't know what to expect because this is my first higher education visit as your regent after having been elected last year. Are you getting me teed up there? Thank you. So thank you, Linda. Thank you so much. Thank you, Kristen, who I owe an enormous debt of gratitude for not only co-conspiring to get you all here tonight, but she's also taking care of my mother. So we know each other in quite different roles, both an employee-employer relationship and as a lady who really was compassionate and helped taking care of my mother, who was an inpatient at Bridgeport a couple of years ago. And also, Dr. Maddie, congratulations and thank you to you. Thank you for having us and for being such a strong sponsor of ACHE for everybody at Quinnipiac. We really, really thank you for it. And Steve Mers, did anybody know Steve Mers, the regent? Of course, you know Steve Mers. So Steve, I will tell a story in case you don't know what a regent is, and I didn't know what a regent was this time last year, by the way. It's almost like the House of Representatives for the American College of Healthcare Executives nationally. There are really two houses. There's the governors, who are like the Senate, and the regents, who are like the House of Representatives. So I was elected to the House this past year, and really didn't check the job description all that carefully. So now I know what I've gotten myself into. So it's a pleasure to be here. One of our high duties that Gina and I share is that we are responsible for the connectivity, for the connective tissue with students and undergraduate and graduate programs in our state. And that is one of the Regent's primary duties nationwide once they're elected. And so I have the privilege of being here first. This is my first time to discharge those duties, so it's a pleasure. And thanks again for having us. We're going to tag team on some formal presentation material. And if it's boring, I beg your pardon, but then what we'd really like to do is open it up to questions about, we have kind of an early careerist, an early mid-careerist, and a mid-careerist. And, we've had different tracks and different experiences, and we're both open to talking about those, how ACHE has helped us in our careers, about our academic preparation, and about our careers. So I have a feeling that might be some of the more interesting material anyway. So let me tell you a little bit more about myself. I'm an accounting major. I had an accounting degree from Miami University in Oxford, Ohio. Miami of Ohio was a university when Florida still belonged to Spain, by the way. Not that I resent Miami and Florida. But then I went on and got a master's degree in hospital administration in the School of Public Health at Ohio State University. So the 2 years yet undefeated Ohio State University Buckeyes. Not that I'm counting that either. Go Buckeyes. You're a Buckeye? Outstanding. So that's my formal training. I did a 2-year fellowship after that, which I'd love to talk about fellowships if anybody's interested in talking about them. I was fortunate enough to apply and receive a 2-year fellowship in Louisville, Kentucky at a place called Norton Healthcare System, and then had some progressively more complex jobs after I finished my fellowship. And my daughter is 17, and she has moved 6 times. So that's another thing we can talk about in the career path, is that there are pros and cons in moving around, and there are pros and cons in not moving around. And so we can talk about that a little bit too if you want to. But I'm not moving anymore. My wife has told me that, and I trust her. So let's go through the prepared material, if you don't mind. And start first and foremost, as I do when I'm welcoming any new employees to Yale New Haven Health System or Bridgeport Hospital, I always start with the mission, vision, and values, because it's the buttress, it's the foundation of everything else we do. And so the same holds true for the American College of Healthcare Executives. By the way, which I joined when I was at Ohio State. So I joined ACHE and have been a dues-paying, card-carrying, very active member since I was sitting in your chairs. And I've never let it lapse, and I've never regretted it once for all the reasons we're going to talk about. It's been an instrumental part of my career growth and development. So the vision. So the vision is where we're headed, right? It's not why we were founded, but it's where we're headed. But it's to be the premier professional organization for executives dedicated to improving the healthcare delivery system, for improving the health of our communities, which is a different challenge than your medical school or your nursing colleagues who have an enormously high calling, but their calling is to see one patient at a time. And our calling is to see hundreds of patients at a time. And it's different. It's a different responsibility. There's different civic duties. And this is the organization that's dedicated to those who are dedicated to a similarly higher calling, but not taking care of a patient at a time, but a community at a time. And the mission is why we're here. And so the vision is where we're headed. The mission is why we're here. And the mission is to advance members and healthcare management excellence. To advance us, and it's to advance the profession. And that's a pretty noble calling in and of itself. So, that's kind of the foundation of the organization. The values. So again, if the mission is why we're here and the vision is where we're headed, the values are kind of the words and that bind us. It's the behaviors that bind the organization and bind its members and really are the essence of the code of conduct, which is an important part of the career as well. First one is integrity. So advocating ethical conduct in all we do. There is we could sit around and come up with all of our own individual definitions of integrity. This is the Congress, this is ACHE's, and I think it probably resonates with you. One of the really important parts of advancing in ACHE, and there's an advancement in a credentialing process that we're going to talk about, is the code of conduct and the ethical standards that apply to every member, and so it sets a national uniform standard for the profession that I'm proud of. Lifelong learning. That's pretty self-explanatory, isn't it? You already read the words behind it, but this is really, in my humble opinion, one of the 2 top benefits of being a member, and it's where a lot of the return on investment comes from your membership dues and your volunteerism, and there's plenty of opportunity for volunteerism. Leadership. Hopefully everybody's motivated to be a leader or you wouldn't be sitting here. You are motivated to be a leader in the field and in the career, and there are plenty of opportunities through volunteerism to give you experience in leadership that will also help your profession. And diversity, advocating for inclusion, to embrace differences in those who we work with and those with whom we serve. It's a really important facet of the American College of Healthcare Executives, is to ensure that there is not only an understanding of diversity and inclusion in the patients we serve, but also in the colleagues with whom we work and the medical staffs with whom we work. So it's multifactorial, and it's something that is really growing in seriousness and importance and focus from the American College. Here's what it looks like. So this is a snapshot of what the organization looks like. You know how many hospitals there are? Now, not everybody's going to work in a hospital because there's lots of opportunities in insurance and long-term care and population health and public health. But just out of curiosity, anybody guess how many hospitals there are? It's about 5,000. About 5,000 hospitals in the country. And this organization has diversified over the years in membership and focus and education, but it started with hospital administrators. That was kind of the building block, and has grown into over 40,000 members, including 4,000 associates, student associates, and 3,500 fellows, which is the highest credential that you can receive.
So thank you again to Kristen and Linda for putting this all together. Thank you to all of you for coming out. Thank you, of course, to Angela. She's always been a partner, a collaborator in terms of getting students involved and engaged in ACHE. So my name's Geno Calder. I'm the Administrative Director of Geriatric Services and Patient Relations at Bridgeport Hospital. I studied psychology as an undergraduate at Yale University, and then went back a couple years later and completed my master's in public health there, focusing on health policy and administration, also at Yale School of Public Health, and joined ACHE as a graduate student. So very much like Bill, was introduced by executives in nearby organizations to the organization, to the American College of Healthcare Executives, saw the benefits right away in terms of networking and opportunities for internships and being able to have a better understanding of what my career path options were, and have never allowed my membership to lapse, have been extremely active ever since. Like Bill, I'm also a fellow of the college. So we'll talk a little bit about the process to become a fellow, and also completed an administrative fellowship after finishing my graduate program, a one-year fellowship with Yale New Haven Health System, and I'm still with Yale New Haven Health System. So, I think, again, those relationships that I started to form through the American College really helped to propel me in terms of my career and the different steps that I've taken after. So encourage all of you to become a student associate, very important. So you have a number of benefits as a student associate. You have access to our online portal. The association, I think, is very forward thinking and really looking at the best way to link people all across the country to the various opportunities and resources that they have. So when you get into the online portal, you'll find anything you want. In terms of lifelong learning, there are opportunities for webinars, you have access to journals, you have access to various chat rooms and opportunities to talk to colleagues and other students across the country about things that they're interested in or working on. So that's extremely important. There's opportunity for financial assistance. We'll talk about that as well. as well as opportunities for leadership, internship, volunteer opportunities that will help to prepare you for your careers. So in terms of the publications for ACHE, we have a couple of them. We have the Healthcare Executive magazine, and then we also have the Journal of Healthcare Management and Frontiers of Health Services Management. Those are our 2 peer-reviewed journals. So we, just like any of the other healthcare-related fields, the clinical fields, we believe in doing research and having peer-reviewed publications that will help our colleagues around the country understand how to better run their organizations, how to better serve the communities that they serve. And then we also have specific newsletters. Yes, absolutely.
I got to get near the microphone. Did I just turn something off? No. Just an example of one of the most recent articles that was in the peer-reviewed journal, just to give you a flavor. Some of them are like trade journals, and some are more scientific. So an article in the most recent edition was a study that was done on staffing levels of housekeepers in acute care facilities and in long-term care facilities, and the correlation between the housekeeper ratios and overall patient or resident satisfaction. So, you know, it's stuff that we love. We love this stuff, and it's scientifically peer-reviewed, to your point. So that's an example of the kinds of things that are out there that really can help, because otherwise, without it, you might have a knee-jerk reaction that, of course, if we hire more housekeepers, that we're going to get better patient satisfaction scores on cleanliness, and it's not the case.
Thank you, Bill. So it's important that we have those resources so that as we're making decisions, as leaders in our organizations, we have some tools that we can utilize to make better informed decisions. So very important. And then we also have the ACHE News and the student newsletter as well, that are online versions. The ACHE actually polls its student associate members on a regular basis to identify the various topics that students would like to see presented in the newsletter, and then you also have opportunity to contribute articles yourself. So some of the educational opportunities offered through ACHE include the annual Congress. I attended the Congress as a first-year graduate student, and that was one of the things that just kind of helped seal the deal for me. To be at one location with tens of thousands, honestly, of healthcare executives from around the country at all levels, in terms of where they are in their careers. And as Bill mentioned before, the organization is diversifying in terms of the types of organizations that are represented. I was just amazed. I was completely amazed. Made some connections that I've kept even into this day. Always attend Congress, each and every year. And as a chapter here in Connecticut, we actually support students to attend the ACHE Congress. So we will cover your tuition, we will cover part of your travel expenses to be able to attend, and that occurs in March in Chicago every year. So you can definitely talk more with Linda and Kristen about the details of getting involved and being able to go to Congress.
Weather's always beautiful in March.
Oh, sure, in March. So in terms of financial assistance, there are a number of scholarships and essay contests as well that ACHE does. I'm sure many of you are already kind of looking at your tuition loan debt loads and kind of saying, whoa, I really hope this was the right choice for me. It was the right choice, but we do recognize that higher education can sometimes be a burden. And so ACHE does offer the opportunity to kind of lift a little bit of that burden.
For the last one, essay competition, if you're taking my healthcare quality course, you have an option of participating, but even if you're not and you want to participate, email me and we'll put you in the bin, because we do a selection process, and the best essay from Quinnipiac gets sent on to ACHE. So not only does it have a little bit of a stipend attached to it, but it also has an additional networking opportunity,
Absolutely.
credibility opportunity attached to your name. So take a look, get on their website, take a look at that.
All right, so how do you become a student associate? So this is kind of the reason why we're here tonight. So the student associate fee to join ACHE for a given year is $75. As Angela mentioned earlier, our chapter will sponsor a scholarship every year that allows for students to join through our chapter for a total of $25. So basically what you do, you work with Linda and Kristen, say, I really want to join ACHE as a student associate. There's a process that they'll take you through, and you'll be able to be reimbursed $50 of the $75 that you pay for the membership fee. And that, at this point, will take you through to the end of December 2014. Okay, so we'll cover the full, the rest of this calendar year as well as next calendar year. And then what ACHE allows you to do is roll your student associate rate over until you kind of get to a point where you're no longer a student. So if you join now, let's say your first year, you'll be able to carry that student associate rate through until the December after you've graduated. If you're a second year, same concept. If you decide to go back on for continued education, you'd be able to maintain the student associate rate for as long as you are a full-time student or part-time student. So here are some of the benefits of and kind of the trajectory for folks who join ACHE as a student. You want to make sure that you join ACHE before you graduate. Again, as Bill and I shared from our own personal experiences, it'll really help you to make decisions about your next steps, whether you seek administrative fellowship opportunities, kind of where to look for internship opportunities, maybe where in the country you may want to end up, what types of organizations you are looking to be a part of. You graduate, you maintain that membership, and eventually you're able to transfer your membership status over. So for me, for example, when I graduated and moved into an administrative fellowship and then finished the fellowship, it was a very streamlined kind of transaction to move me from student associate to full member of ACHE. And because it happened kind of in the middle of a year, they didn't expect me to pay additional dues, which was great, because I hadn't had any paychecks coming in just yet. And then after, you kind of finish out that partial year, beginning the next year, you would pay dues as a member to begin the next calendar year. So it's really important to join now, kind of while you have the opportunity to gain some of the benefits of ACHE at a discounted rate. And then as you move forward in your career and can move on to full membership status, you already have made some connections, you'll already be well networked, and definitely see and realize the benefits of membership and want to continue that status. So again, we are here to encourage all of you to take the step that Kristen and Linda have taken, that Bill and I have taken, Angela, many of you in the room, Marta, and join ACHE. It's an amazing organization, definitely for me helped to crystallize where I wanted to go and how I was going to get there, was able to identify mentors who really have supported me throughout my career, looking forward to continuing those relationships, but then also allows me to reach out and be a mentor as well. There have been a lot of people who have kind of contributed to my success, and so now I want to be able to do the same and give back and contribute to the success of others. So I have the opportunity to do that through ACHE and welcome you all to come on board and be a part of it. So thank you. So we'll open it up to questions, I think, now.
I said in my remarks, is it okay if I use this? Okay. I said in my remarks that that the education was one of the top two benefits that I've received, and the reason I've stayed active for since I was 20. And that's probably is the number two reason. I think the number one reason is networking, and Gina has mentioned it, and that is a valid reason to be part of a professional association, is to interact with and grow and develop and meet people that have your same interests. It's also a pretty good job for the job search. And so going to Connecticut chapter events can be a little intimidating, and so I have a trick to share with you. or technique, trick sounds bad, technique to share with you. Going to Congress is flat out overwhelming. I mean, there are hundreds of people in these conference rooms but you gotta go. You gotta go to ACHE Congress. It's nuts, and every year you go, you'll be a little less intimidated. And you also start having friends there, which makes it even more fun. So you have to go and network, and there's a variety of reasons. One is it's fun. I mean, socializing, having an adult beverage in the bar with somebody else who is on the career path that you want is important. It's an important way to learn and grow and develop, and to share and to develop mentors unofficially. And so here's my technique that I recommend, not in any journal, that whenever you go to any event, any professional event that's at ACHE, don't go in trying to meet as many people as you can, because you will be overwhelmed and you probably won't succeed. You'll spend probably less than quality time with everybody. My advice is go to any event and have a goal of meeting one person, no matter how many people are there. Say, I'm going to get one card, I'm going to make one friend, I'm really going to know them, they're really going to know me, and I have no idea in this sea of humanity who it's going to be, but it's going to be one person here tonight. And you will succeed at that. I promise you, you will succeed at that, whether you're at a state chapter event or whether you're at Congress with 40,000 people walking around. You'll make a friend. I absolutely promise you. Second reason, this is the dirty underbelly of our business, is that there are headhunters all over the place at these events. And eventually, you will make friends with one of them at the bar, or at a break or wherever, in the lobby by the front door. And you gotta get to know them. You gotta get to, anybody a headhunter in the room? Anybody gotten a job from a headhunter in the room?
Yeah, well, we have somebody on our advisory board, Roz Tree, who teaches as an adjunct and also sits on our advisory board.
So
that's the reason why I put her.
It's a vital part of the industry that you're entering. A lot of jobs are from who you know and networking, ACHE benefit, and a lot of jobs are through some of the significant healthcare search firms. They're all members, and they go to everything because their job is to field as many quality candidates as they can. They don't get paid by you, they get paid by the client, but their job is to know as many quality people as they can, and that's where they go with the idea of meeting one person at every event. So that's my free advice in the dirty underbelly of the headhunters. You absolutely have to get to know them, and the way to get to know them is, this is going to sound like I'm selling ACHE, and I guess I kind of am, but the way to get to know them is to be a member, because it's the first database they go to. For mailing lists and email lists, it's the first one they go to. So it's almost like being in the club, which sounds like probably not a very professional way to put it, but that's really kind of the way it is.
That is the way it is.
It's the way it is.
Definitely. And the advice wasn't quite free, Bill, because you did get a cookie.
I got a cookie. It was a good cookie. It was oatmeal raisin.
Do you guys have any questions for ACHE? Or, the other thing we did do is we said that you would talk a little bit about being a hospital CEO in Connecticut under these times. And Gina, as someone who's a member of an organization, if you want to just discuss the landscape in Connecticut, M&A activity, whatever you want to do. I think they're interested in hearing that also.
I would describe it as frothy. That is a word that describes what's going on right now in Connecticut, and for that matter, nationwide. It is frothy. Another way to put it is everybody's talking to everybody. If you're a doctor or in a medical group, you're talking to all the hospitals and the other medical groups. If you're a hospital, you're keeping your cards close to your chest. You are talking to everybody to try to figure out where you fit. If you're a Griffin Hospital, anybody here work at Griffin? Griffin's a successful, independent, private, not-for-profit hospital in is it Derby? Derby. In Derby. There aren't many of those out there anymore. There aren't many Griffin hospitals out there anymore, and eventually, Pat Shermell's a good friend of mine. He's the CEO there. Great guy. Pardon me?
He's
graduate this program.
Undergrad.
Great alumnus of the program. He is as value-driven as any hospital executive you'll ever meet. and he is bound and determined to stay a private, independent hospital for as long as he can. I don't know how much longer he's going to be able to do it, as valiant as his efforts are being. So it's frothy. So a lot of people, if you're an independent entrepreneurial spirit in medicine right now, it is virtually impossible to stay in private practice. It's any doctors in the room? No? The compliance world, the employment rules, it's just the reimbursement, the rules are absolutely overwhelming to the point where if you got to take care of 20 patients a day just to pay the bills, you can't do that and still take care of the regulatory and the compensation and human resources environment and understand the lease you're paying. So that's why the medical world is frothy. The reason the hospital world is frothy and there's consolidation occurring is because reimbursement's going down so rapidly. Some examples. You all probably studied or read the paper and understand the Medicaid challenge in the state of Connecticut. Everybody likes to think they're different, and everybody likes to kind of woes me, like, oh, Connecticut's awful. The governor cut $500 million over 2 years. That's bad, don't get me wrong. And I'll tell you how it translates into our lives and our world. But every governor's doing this. No governor is adding money to Medicaid in this country. It's not happening. So Tennessee, if you're a hospital CEO in Tennessee, you're going, oh man, it's called TennCare. TennCare is the worst. It's got to be worse than it is in Connecticut. And then you go to California, and it's called Medi-Cal, and they say it's terrible. It's much worse than Connecticut and Tennessee. So it's kind of all the misery being shared. So I tell you this because we're not different. As much as everybody in Connecticut would like to tell you we're different, we're not different. And as many people that tell you or you read about that say healthcare is so frothy they can't really predict where it's going, I think they're crazy because I can predict where it's going. People are going to pay us less. And so if you're an effective leader, and whether you're leading, our organization's a $500 million organization. We're part of Yale New Haven Health System, which is almost a $4 billion organization. So whether you're a $500 million company or a $4 billion company, we're getting paid less. And there's going to be more regulation. I don't know how much more I need to know right now than about where we're going in the country. The Medicaid trust fund's going bankrupt probably in 2017, maybe 2018, maybe 2019. I don't know that it cares. It's going bankrupt. They're going to pay us less. Medicaid is going bankrupt. We got whacked $500 million this past year for a 2-year budget cycle. There's going to be more. And so our challenge is to continue to maintain the standard of care and a safe environment for all of our patients and to become more value driven. And that is, if you think of the equation of what value is, the value equation is quality, however you measure it, over cost. Quality over cost is value, no matter what you're producing. So we have to either continue to improve the quality of care while reducing the costs, or certainly reduce the cost and not reduce the quality of care at the same time. So that increasing the value has to continue to happen because nobody's paying us more. And I know regulation's going up. So that's why I say when people say we don't know where healthcare's headed, that's where it's headed. So we might as well not waste any time. We've got to get busy focusing on how to drive more value through our operation and through the communities we serve. Whether that means we're driving out errors and duplication, or merging and forming larger organizations with greater scale to capitalize on economies of scale. So instead of having 5 housekeeping executives, you have 1 housekeeping executive over 5 hospitals. Those things add up. And so, again, there's not that much of a mystery, in my opinion, where we're headed. There's some mystery around population health, about how fast that's going to happen, about how much of the income stream for our hospitals, population health, is going to, how quickly it's going to become the predominant payer source. But if and when we get to an environment where population health is the predominant payer, our costs have to be lower. So we got to keep driving value anyway to prepare for that.
Absolutely.
So now I've started to ramble.
Yeah. No, I think
that's
that was great. That was
And
great.
If I could just play off of that, and Gus, I hope you don't mind, I'm gonna call you out a little bit. We have.
Well, Angela, I'm sorry, if you don't mind, I just wanted to kind of talk from the kind of, director level on that same exact point. So Bill's job really is to kind of set the vision and set the direction for the organization. So he'll, make sure that we understand the message. Healthcare is going in this direction, reimbursement's going down. So we have less and less money coming into the organization, and the way that we're delivering healthcare is going to shift. When exactly that's going to kick in, we're not sure. So the message to us then is, you need to be creative. Okay, we at the leadership level, kind of middle level leadership and vice presidents, need to determine how we're going to get the cost down, how we're going to get the quality up, and do those things simultaneously. If we have other institutions out there that we can partner with in terms of providing care, maybe in different settings, maybe we need to start some pilots and look at some new initiatives to make that happen. Maybe we need to rethink how we've even organized and structured our departments. Maybe we have certain types of roles that have always existed. Are they the ideal role? Let's ask that question. Let's kind of re-engineer maybe some roles, some responsibilities, some tasks. How do we make things more efficient? How do we become more effective? How do we, get to a point where we can say, okay, we used to do this with 5 people. Let's figure out how we can do it with 1. Or maybe we used to always provide this type of care in the hospital, and we're doing a lot of that now. Well, maybe we need to look at opportunities to provide it in a whole different setting, in a whole different place. The patients are more likely to want to travel to receive care, and let's start to think about shifting the way that we've used space within the hospital a little bit differently. So that's kind of what we end up doing. Bill sets the vision, we then have to execute. We've got to kind of come up with how we're going to get there. He's kind of put in place where we need to go. We've got to then drive ourselves to get there. And then Bill will hold us accountable for making sure that we're meeting whatever the targets are. But I think it's actually a really exciting time. It's definitely uncertain, definitely ever changing, and quickly doing that, but it's a great time to get into this field. Anyone who has energy, anyone who has a passion about serving people, serving the community, anyone who's willing to be creative, innovative, is able to deal with uncertainty, this is the field for you, and now is the time to get in. So I think especially for folks at your level who are preparing to enter healthcare, this is the best time to do that, because there are just all kinds of different game changers that are happening. The government is really rethinking how they want to fund and support and reimburse for healthcare, because they're running out of money. So we do know that the reimbursement will continue to decrease, but we also know that the needs will continue to grow. The demand is going to continue to increase. So how do we, if we have limited resources, care for more and more people? And that it really calls for creativity and innovation.
So with that, let's go to the other part of the value equation. And Gus Velez,
Yeah.
he's the president of the Connecticut Center for Patient Safety.
Who's Gus?
Hi, nice to meet you.
So could you, there was a recent report that just came out that said, not only are we not doing better in terms of patient safety, but we are now, it's the 3rd leading cause of death. And correct me, Gus, because you live and breathe this stuff, but there's an article about a month ago that came out from the journal Patient Safety that said, at one point where it was the 8th leading cause of death, medical error or iatrogenic issues. It's now the 3rd leading cause of death. So can you probably talk a little bit about what's going on at the Hospital Association in terms of your huddles and I'll just...
There's, I don't know if you all studied high-performing organizations or if you've studied any of the science behind reducing errors, whether it's in manufacturing or in air freight or nuclear power or healthcare. A lot of the principles are exactly the same. That makes a lot of people in healthcare feel uncomfortable because we're not nuclear power, we're not aviation, but they're a lot safer than we are. Their error rate per million parts is much
safer than we are. I wish I had the slide, but if you take a look at errors per million and you chart it, it's not linear. But you can actually place industry standards on errors per million and put healthcare up there. And healthcare is not much better than getting your luggage to the same city you're flying to in a commercial, a domestic air flight. So there's a lot of work to be done. So what are we doing? It's raising the awareness and the culture and the importance of safety and the importance of identifying near misses and the importance in reporting near misses and the importance about talking about it every day. So if you have an error, it's too late. If you work at Sikorsky and they call it an escape. Have you ever heard the word escape? An escape, in the words of the engineers, is when an error in the process inside the building gets to the customer. We have escapes. We have medication errors that kill people. It's not private. We had one of those on the front page of the paper last Saturday from Bridgeport from about 4 years ago, where we had a medication error that thank goodness didn't kill somebody, but it harmed her for life. And a jury in Bridgeport awarded her punitive damages of almost $10 million. It was an error. We admitted it, but it was an error that escaped and harmed the patient. So how do we stop that? The only way to stop it is vigilance, and it's vigilance and technology. So it's not training more. The science of error prevention and reduction in healthcare has demonstrated over and over and over again, training doesn't get it, because people forget the training and we're humans. And we make mistakes and we get tired and we work 14-hour shifts when we're supposed to work an 8-hour shift. So training and education don't get it. You have to put processes in place that prohibit an error from being made. I'll give an example of what we're doing now, and I'll give it a biomedical example, and then I'll give a process example. The process example is the Huddle. So every morning, you've been to a Huddle?
No, but
Okay.
I might ask Patty if I can come.
Come. You don't have to ask her. Tell her I invited you. Come on. So every morning at 8:15. So this is cultural. You have to have a culture that drives out fear, that makes it okay to report a near miss, that makes it okay to report an error, no matter if it's harmed the patient or not. And so for 10 minutes every day, every leader at Bridgeport Hospital, so there's 100 people, go to the library. It's a room twice as big as this, and it's a standing meeting. And I don't mean that metaphorically, I mean it literally. You can't sit down. No one's allowed to sit down. And we stand and we do a roll call, and then whoever's leading the roll call says, does anybody have any patient safety concerns from the last day? And sometimes people say yes, sometimes people say no. Sometimes it's about medication, sometimes it's about a security issue where a patient got violent. Okay, we chronicle them, we do process improvement. We don't solve it there because we're only going to be there for 10 minutes. And then the next question is, does anybody have any concerns about the next 24 hours? And hands go up. Yeah, I have a concern. I have 2 people that are out, and I know that we have a patient that weighs 800 pounds that needs to be turned, and we don't have the right people to turn this person. So we talk about it openly. It's part of the culture to talk openly and freely about errors and safety without fear of retribution. Has anybody ever read any books by W. Edwards Deming? Have you ever heard of Dr. Deming? Read his books. If you haven't, it's maybe 25 years old. He's the guy that started the revolution in Japan and started the revolution that created really the Japanese automobile industry becoming as high quality as it has become. Anyway, Dr. Deming had 12 points. Remember the 12 points?
Drive out fair was one.
That was the first one. You stole my line. So he had 12 points for creating quality in any organization. And the very first one is you have to drive out fear. Nobody can be afraid to say good news or bad news. And so our huddle is to help drive out fear and make talking about patient safety part of the daily vernacular. And it wasn't a few years ago. Can you attest to that?
Yes, I can.
It was not part of the culture. You hid problems. And if you have 50 nurses, I'm making this up, this doesn't happen at Bridgeport Hospital, But if you had, 50 nurses making the same mistake and everybody was hiding it, no one would know there was a pattern of errors happening, even if none of the people weren't the problem. It might have been a pharmacy problem. So anyway, but then there are biomechanical or biomedical ways. There was a patient injured a few years ago in Connecticut, in a Connecticut hospital, where in the operating room, the hoses for oxygen had the same coupling as the hoses for an anesthesia gas. Can't remember the gas. You all remember the story?
I think it's nitrous oxide.
Nitrous oxide. Okay, you remember the story.
Yeah.
And somebody, good intended, this person woke up in the morning not to harm a patient. This person came to work to save lives and heal and comfort. But somebody in the operating room switched the hoses and the patient died. Well, that wasn't a bad person. That was a good person. The hoses should never have fit in the same openings. And so that was the solution. It wasn't creating a culture of safety. It was fixing the problem mechanically so nobody can ever do it again. The hose won't fit in there. And so we have to keep finding those things. And the best way to find them is in a near miss before harm reaches the patient. And that's why you have to talk about near misses. And that's why you have to applaud somebody who catches something before it is an escape, not punish them. And we applaud people. We give trophies. We give trophies. Yeah, great catch.
So, and that was
Anything to
great.
add about the huddle or the
I mean, I think what's happened as well is it's kind of spun off. So it started off as, a leadership huddle. And now you can go to any unit throughout the organization twice a day at least. Everyone is having huddles for their team, for their unit, for their department, to be able to talk about maybe more local issues that have come up. And it's the same, creation of this culture of safety, which means you're safe to talk about errors or near misses or, concerns you may have. Maybe you notice something and don't quite think that it works as well as it should. But now you feel like there's a forum and there's a trusting environment for you to bring that forward. And as a team, we can talk about how we can reduce those errors and create safety for our patients. Yeah.
How about you guys? Any questions, comments? Yes.
This huddle of leadership, how long has it been established?
How long have we been doing the huddle? We've probably been this year. I think we started at the beginning of the year.
So it's basically new? Something new?
I wouldn't say it's new anymore.
Oh, okay.
We've been doing it 10 months. So I wouldn't say that's new.
For us, new is about a 30-day.
Yeah, that's part of the culture now. In fact, I was worried. To your point, I think this is your point. Is it going to last?
Yeah.
Are y'all going to stick with it?
Yes.
Is what you're thinking. The answer is yes. I was worried that after we started it, that it would be this burst of energy and lots of activity and lots of participation and interest, and then when we'd start winding down and people would start trickling off and no one would come. Really, the exact opposite's happened. Kristen's a perfect example. Kristen just said, "Can I come to the huddle tomorrow?" So people want to come to the huddle because it's the cool thing to do, and everybody's there, and you know what's going on. Even if we didn't have an error yesterday or no near miss, you spend 10 minutes at the huddle, you know what's going on in the hospital. And everybody likes to get the news first. That's why we have the little, the things that are on your iPhone that are the news flashes so you know what's going on CNN. You want to know first. It's no different than at the hospital. Everybody wants to know what's happening.
Thank you.
Did I answer your question?
Yes, thank you.
Any other comments? Yes, please. Anthony, right?
Yeah, you're good.
I usually know all of them, and now it's online, so.
This is for Bill. Clearly you've made some cultural adjustments to the hospital since you came. That's something that's really interesting to me, so I was just wondering where you started when you came in.
This is going to be tough because Gina can keep me in check on this, and so can Kristen, because they've been with me all the way. I think the first thing I did is I really drove accountability and transparency, and so those two things, I think those are the two words I'll stick with for everything. I drove transparency and accountability, and I mean transparency with everything. How are we doing economically? What do our errors look like? Let's graph them. So I'll tell you a story. And then accountability, I don't know if that's self-explanatory, but look, I'll give everybody every chance. I'll give everybody training. I'll give them tools. I'll give them a second chance. But eventually you got to call the question. And if you're a nurse manager, and you've been around for 15 years and your patient satisfaction scores stink, and we've given you remedial training, we've given you all the tools, and your scores are getting worse, you gotta go. I don't have time to do that anymore, and the patients deserve more. So eventually you gotta call the question on accountability. I'm not a mean guy. I have pretty good high value standards. But I would maintain that not moving somebody out is a violation of the value of excellence. So holding people accountable has been a serious part, and being willing to move people out as well as moving people up. I was quoted early on. It has become almost legendary, dare I say, to tell people that if they wanted help, I'd help them find their successes elsewhere. And I have done that with some people. And again, not in a mean-spirited way, but in the spirit of continuous improvement and actually moving the needle. There's some people, now I have a metaphor that I use all the time with my team. You've never heard this, so it'll get out now tomorrow in the hospital. But I always talk about movement. We got to have movement in clinical improvement and economic improvement and patient satisfaction and employee satisfaction. We have to continually move. And what I mean by move is improve. Anybody can give me motion. Lots of people have lots of motion and are always busy and are always, I don't pay people for motion, I pay them for movement. And there's a big difference, and it's not hard to identify those that are moving versus those that are just in motion if you have transparency. And that's where the two things are connected. We measure everything. We measure everything, and we talk about it publicly, and we don't embarrass people, but if your patient satisfaction scores are going down for the fourth quarter, we talk about you in front of the group in front of you and ask you why. And here's my story. In labor and delivery, anybody here, I know there's one nurse. Anybody familiar with labor and delivery other than delivering a baby? So there's a measure in labor and delivery, a quality measure called misdeliveries. And it doesn't mean dropping a baby. What a misdelivery is when you have been going to the same OBGYN for years, or at least 8 months, and you're scheduled to deliver, or you deliver spontaneously, but the doctor who is caring for you can't make it to your delivery for whatever reason. They're in the operating room, they're at the country club, they're in Italy, they've missed your delivery, right? That's a quality measure because it's not as safe. I mean, it's not dangerous, but it's better if the person that delivered your baby knows you. I'm sure there's a more scientific way to describe this than I'm giving it justice for. But misdeliveries is a common measure in obstetrics. And our misdelivery rate was terrible 4 years ago. And so I noticed this and said, let's start posting, you've heard this story, let's put the misdelivery rate out in the waiting room for the dads and the family members, the dreaded department posters. I insisted that misdeliveries be posted publicly for medical staff, employees, patients, and family members to see. And the medical staff went bonkers. And they said, what are you talking about? What if a newspaper reporter comes up here? And I said, well, what if? It's your rate. And so I wouldn't let them take it down. And I did not make friends from the obstetricians by not letting them take it down. But guess what happened? It got better! Almost immediately it got better. Because we were focusing on it, and because it was public, and because they were being held accountable. It's really amazing. Because I knew they had the tools. It wasn't like they didn't have the resources to do it. It would be a different situation if I was giving a goal or an aspiration or an expectation and somebody didn't have the right training or tools. That would just create a demoralized team. They had everything they needed. So I think that's probably part of it, is creating pride, holding people accountable. By the way, wherever you work, most people work full-time and are full-time students. You know who's not pulling their weight. Everybody knows. So how can they still be here? And I called that question. And you know what else I did? I gave people permission to take care of their own teams.
And that's what I was actually going to add, is that I think the beauty of creating the culture and having it start from the top is that you then send the message through the ranks of the organization. So, someone in my position, I see what Bill's doing and I say, oh wow, okay, I can hold my people accountable. And if they're not meeting their performance targets, if they're not doing what I've asked them to do, even though I've taken the time to train them, I've equipped them with the tools they need, I've made it very clear what my expectations are, and they're not doing it, I can quote Bill and say, I'll help you find success elsewhere. And that's what began to happen. And it sent a message all the way through the organization to frontline staff who were there each and every day, working hard. They were dedicated, they were committed, and they knew of people or worked with people who did not put in, the same 110%. And so it was reassuring and reaffirming for them that they were working in the right organization because we cared about and we were supportive of their efforts and recognized that if there were other people in the organization who, didn't fit well, we could help move them out. So.
We told any lies?
Not at all.
Okay.
And I think that making the hospital,
Making the hospital look good, like I said earlier, it makes me really proud to work there. And I think it's beautiful when you walk in and people automatically expect really great care because it looks so nice. And the closed off campus and everything, it just makes it look, when I go to classes elsewhere and then I would come back to work prior to all these renovations, I was like, wow, all of these other hospitals look beautiful. And now I walk in and everyone who hasn't been there in years are just so impressed. Our patients, well, this was my first time down in the lobby since the last time I was in the hospital 8 years ago, and how fantastic it looks. So, and it makes it look like it's a really high quality institution as well. So I think you've done that really well too.
So you all, Disney, the Disney Institute, you all read any books from Disney Institute or studied the Disney Institute? Toyota, General Motors,
Well,
General Electric.
All these Deming,
Yeah.
anybody who's taken the healthcare quality course, I'm a Deming.
Guru, yeah.
Well, no, guru, no way. What do you call it?
Disciple.
You follow
You're a disciple.
No, you follow the rock bands around. What do
Groupie. You're a groupie. You're a Deming groupie.
I'm a Deming groupie, but the Disney book, it's all on the reading list for
Okay.
patients.
Be our guest.
Be our guest.
awesome. Just in case we don't have enough
So the reason I invoke Disney is not to get into the Disney philosophy of improvement or exceeding customer expectations. By the way, you'll hear it. Because you'll hear people say, gosh, at Toyota they do this. We ought to do this at the hospital. And somebody will say, this is healthcare. We can't learn from Disney. I say, they can. We can learn from them a lot. And one is about first impressions, Kristen, so thanks for bringing that up. Toyota, GE, General Motors, Disney have researched and published stuff on first impressions. So it's not a secret. I was talking about the Polynesian with you. Who was I talking about the Polynesian with earlier today? Somebody here. Anyway, the Polynesian. Have you ever been to Disney World?
Yeah.
You've been to the Polynesian?
That's where it's at.
It's one. Okay, so the Polynesian is one of the on resort Disney hotels, and it's a Tahitian theme. The Polynesian, right? All their hotels are themed. If you haven't been there, and so you walk into the lobby. And you think you're in Tahiti. I mean, the lobby is like being in Tahiti. The guest services people are all in costume. They treat you like you're in Tahiti. You think you're there. Your kids are going crazy because they think they're there. It wows you. And then you get to your room, and it's just a regular room. But nobody remembers the room. Everybody remembers the lobby, like me. And I believe that transcends every industry, especially healthcare, especially if your first impression is healing and comforting and calm, as opposed to a security guard with a badge saying, stop. You're going to think you're in a Greyhound bus station or in jail. And that doesn't help anybody's attitude or willingness to want to come back. So we've made a pretty significant investment in first impressions all the way from the garage. I mean, I'm not kidding you. You'll think I'm crazy and have obsessive compulsive disorder, but we changed the garbage cans in the garages because they were nasty. And nobody wanted to get near it to put their garbage in it, so there was garbage all over the garage. You were laughing. It's the truth.
I didn't notice yet, but now I'm going to look.
So, I mean, it's that attention to detail really does matter. And if people say, well, that's not patient care, baloney. It affects people's perception because the patient care is already high. We can already prove that. It affects people's perceptions.
Yeah. And I think Kristen said it too, it affects staff morale. I mean, I remember when the bridge was first carpeted with the carpet that has our logo in it. I remember walking across the bridge that first day, huge smile on my face. I mean, just so proud. I was like, oh my God, who did this? This is awesome. And just imagine how that translates now into how I deal with the people I work with, the patients I'm caring for, their family members. I'm excited. I'm in a place I want to be, and I feel like, you know, the organization reflects the care that I'm going to provide. That just takes everything up a notch. So it makes a huge difference. You know, staff morale, pride, engagement has just risen, I think, again, as a result of now feeling like we can be proud of where we work. So.
Why don't we take maybe one more question or comment?
How about career questions?
Brittany.
Yeah.
Brittany has a
I have two
Brittany.
questions, actually. One, when you're talking about patient error, I know in California, they have like a state rule where each nurse, I'm not sure about doctor, is required and only allowed a certain number of patients to take care of to reduce error. Do you think that Connecticut would do that?
I don't think so, because I don't think it's scientific. I think it's anecdotal. And I think the unions have driven it, because the union's only job is to tax their, people that are in the unions and to make money off people paying dues. There is not any evidence that correlates staffing ratios with errors or patient satisfaction. So I don't think that'll, I don't know if it's going to happen here. I don't think, if it happens here, it won't be based on science, and it won't be based on evidence. It will be based on emotion, and it will be based on politics. Bridgeport Hospital's staffing, our hours per patient day. That's how we measure. I don't measure it necessarily in a 4-to-1 ratio or a 5-to-1 ratio. I measure it in hours, direct patient caregiver hours per patient day. We are one of the most efficient hospitals in the country. And depending on who you are, you might say, well, that's dangerous. If you're efficient, that's dangerous. You don't have enough staff. Our patient satisfaction is among the high, well, it's not among the highest in the country, but it's last week, where were we last week? 65th percentile, something like that. So above average. Our employee engagement and employee satisfaction is 87th percentile, so among the most engaged employees in the country. Our last year, we had the lowest error rate of any hospital in Connecticut, and we made more money than all but one hospital in Connecticut. And our nursing hours per patient day are nowhere near what they are in California. And so my point is, you gotta look at the scoreboard. You can't look at one indicator, you have to look at the scoreboard and all the indicators, and if you can generate a reasonable return on investment, improve patient satisfaction, improve employee satisfaction, reduce errors, and be efficient, why would you not do that? And I don't want the government telling me how to staff. I want Gina telling me how to staff. I don't know if that answers your question.
Yeah, I was just curious.
You gotta look at the evidence.
And do you want to?
So I have a question. I've been in healthcare for about 25 years. And it's the loaded question is sustainability. So the HRO collaborative, high reliability, and all the initiatives that we're all doing in all the hospitals, the demands are even more than they've ever been. So it's that balance of being, vigilant and getting the employees to be, accountable and empowered to through that culture shift of getting us where we need to be. But it's the sustainability which is always the biggest challenge. And you spoke to it a little bit as, at high energy and everybody's coming. We're doing the safety huddles as well. So I think that's one of the things that we all struggle with is every initiative. And some of these can't just be initiatives. They need to be.
It's got to be the culture.
Absolutely.
Yeah.
So I guess I was just going to ask you your theory on the sustainability for moving ahead as the.
Of the high reliability organizations in particular?
I think really with such challenges and such demands with reimbursements and really that fine balance, it's sustaining everything we're doing moving forward.
Yeah, no, I mean, I don't want to be Debbie Downer here, but I mean, there is a break point.
Absolutely.
There's a breaking point, and many of the hospitals in this state that did withstand, so I told you, I would tell you what our impact was of the $500 million Medicaid change. For Gina and I, in the 2-year budget cycle, it's $27 million. So you can't really get $27 million by continuous process improvement. As much as I love Deming, that's beyond that. That's taking a look at programs, that's taking a look at people, that's taking a look at how you spend your capital, slowing down on capital spending. This isn't a finance class. I'm a finance person, kind of. So, but when you get a $27 million whack, something's got to give. You can't just, you can't do it on incremental process improvement. And so what has given for us is we've essentially gone into a hiring freeze. Not complete hiring freeze, but kind of hiring freeze. Direct patient caregivers are being replaced with enormous scrutiny. If you're not a direct patient caregiver, pretty much hang it up. With some exceptions, but there are exceptions. And so we haven't had a layoff. Many hospitals around the state and around the country have had layoffs. We haven't had a layoff. I think it's fortunate we haven't had a layoff because of leaders like Gina who aren't replacing positions. But if you take a look at how many people we had in the hospital last year versus how many in this year, we've eliminated over 60 jobs, and we're going to keep doing that. So we had a layoff. We just haven't interrupted anybody's lives. We also just announced this week, I haven't actually started getting all the real noise from it, a pretty significant change in our employee contribution to our health insurance benefit. So that's not unique, though, to healthcare. I mean, that's not unique to hospitals. That's not unique to anybody. That might be why I'm not getting much noise about it.
They're talking, don't worry.
Yeah, they're talking. So change. Yeah.
They're talking.
So
I haven't opened mine yet. They're talking.
it's a change. So you don't get a $27 million whack without changing something. We were doing at least one nursing unit renovation per year. It's about a $6 million investment to gut a nursing unit and bring it back up to modern standards. We can't do one a year now. We can do one every other year now. So that's what I mean about backing off of capital spending. So something's got to give. There is a point at which enough cuts from Medicare or Medicaid are going to put patient safety, we're going to have to keep peeling back programs because the last thing we can't put safety at risk. That has to, that's the only reason we exist. That's our mission. So what's going to have to give is programs to the communities we serve. And, or hospitals are going to close, or both. But as far as the momentum of the high reliability organization and the enthusiasm around it and the focus on safety and eliminating errors, I maintain that is so core to our mission that's it. That's all we got.
I think the difference too is that you can't look at it as just another initiative. You have to make it part of the fabric of the culture of the organization in order to sustain it. If you haven't been able to do that successfully, you'll know that 6 months later, things will start trailing off. People won't be as excited. They won't be as engaged. So it's got to be part of the culture. And I think, just as Bill said, we're going to, in healthcare, start to really revisit what our core business is. And unfortunately, what we probably will start to see happen is looking at some of the programs and some of the different things that we might be doing in the community, we might start to say, this is not really truly part of our core business. We're going to have to kind of pull it back or be more creative about how we engage in those efforts. So.
I think with that, please.
Can I ask one question?
Yes, absolutely.
You'll
have the last question.
I'm changing careers midstream.
Yeah.
And I'm coming from designing intimate apparel to healthcare. And I've been fortunate enough to get a marketing opportunity at a healthcare facility. One of my responsibilities is to increase the number of beds that are used. In your introduction, it said that you have done that with Bridgeport Hospital. So do you have any tricks up your sleeve? Not tricks.
They're not different tricks. Yeah, they're not tricks and they're not secrets. They're not tricks and they're not secrets. And I really think we've talked a lot about focusing on service excellence, and it is recognized by the consumer. And I'm not bashful about calling patients consumers. Word of mouth gets out there, and our market share is growing. And it's measurable. We measure it by consumer market research that we independent consumer market research that we sponsor, and consumer preference from an independent measurement system clearly show that there's a mindset change of where consumers are preferring to seek health care in the Bridgeport greater community. And it is really being driven by a lot of the service excellence improvements that we've made, some of the first impressions that we've made. The standard of care is already high. It's as high, if not higher, than any hospital in the country. We measure it. We know. We benchmark. The problem is we're in Bridgeport. It's no secret. Bridgeport has an image problem. And so our name is Bridgeport Hospital in Bridgeport, so we have an image problem that doesn't match the same standard of care. And so as we continue to change the image to become closer to the standard of care which we've been delivering for decades, people are starting to recognize it. But they recognize it based on things that our patients can evaluate. And I'm not dismissing how brilliant our patients are or discerning they are, but many of our patients make evaluations based on how clean the floor is. And it's really clean. And they're noticing. And that's important. And I'm not, overplaying that, but we already have the standard of care. We already have the safety measures. So it's also recruiting. I don't mean to make it all about the visuals. That would be, a little disingenuous. But you also have to have the best doctors. You have to have the best nurses. You have to have the most compassionate care. And you have to hold people accountable that if they're not compassionate, they'll work for the competitor. We gladly have the less compassionate people work at the competitor. And I tell every employee in orientation in their first hour of work, if you can't be compassionate, don't come back tomorrow. Go work at St. Vincent's. Because I don't want you here. I don't have time to rehabilitate you. And it's the truth. And that a flywheel effect starts to happen. And that's where word of mouth gets referrals.
That's great. Well, I think that's a wonderful way to end this program. So first, please join me in thanking Gina Calder and Bill Jennings for taking time out from their busy schedules to come here. And before we do that, I want to thank Kristen and Linda, who worked so very hard, and their team in putting this together, and Martha, our former president. So thank you very much. It was a great